managing patients with sleep issues, insomnia, and many of us don't get confused sometimes which medicine to prescribe and for whom. How do we choose the right medication and for the right patient? So today we'll have a discussion on insomnia. We have two faculty, Dr. Seema and Dr. Odette. Dr. Seema is an Associate Director, Education and Research, Karunashraya, Bangalore. She has done her MSc in palliative medicine and has many years of experience as a doctor, and she's a psychiatrist also. She's the honorary tutor at Cardiff University, and she has many publications. And many of you are might be very familiar with Seema. If not, you will be meeting her in the upcoming IAP Con in Bangalore. The second faculty is Dr. Odette. Dr. Odette is a researcher at Peter MacCallum Cancer Center, and she's chairing the Australasian Palliative Link International, APLI. And she has worked in many sectors in palliative care, community hospice, and she has done a lot of work in India, supporting many centers, mentoring many centers through teaching and mentoring through the group in APLI. So it's kind of midnight for Odette. So I think she'll be the best person to talk about insomnia probably today. Welcome, Seema and Odette. Thank you so much for agreeing to be part of this session.
Thank you.
Thank you.
So who will be going first? Is it Odette or Seema?
I think it's me. Is that right, Seema? Great.
Absolutely.
Okay, I'll start and share my screen. Here it is. Thank you. Okay. Now, can you see the second slide as well, or can you just see the main slide?
It's the second slide also. We are seeing the presenter view now.
I'm wondering if I can change that.
Yes, you can. From the menu, you can.
How do I change that?
I think display settings, you can.
Can
There.
go to slideshow. Yeah.
Is that better?
Yeah.
Okay, great. Thank you. And so thank you very much for this opportunity to join you again. I didn't realize this was the final number 17 of your sessions. So well done for participating in the course and getting through to this 17th session. And thank you to Pallium India for inviting me to speak. Now, it is quite late here. We have daylight saving also in Australia, which is perhaps another cause of insomnia for some people. So if I do kind of fade a little bit, I might have to leave the session a little early. I hope that's all right. But I'll do my best to stay till 1:30. Well, I think it's going to be 2 o'clock actually, my time, so I might fade. So excuse me if I do. But I am really just going to provide a few very sort of introductory points, and leaning very heavily on Dr. Seema to do the bulk of the work for tonight's session. So there may be a little bit of overlap in what we say, but perhaps I think it's late for most of you, and many of you have been working today, so perhaps it doesn't hurt to hear things twice. It helps us to remember. So I'll just start with a patient story, and actually this was a man I saw only this week at home on a community visit. He's a 65-year-old man with a metastatic melanoma. He had a lesion on his back, which was excised about a year ago, wide local excision, but unfortunately within a few months he progressed and was found to actually have brain disease involving both the cerebral cortex, but also he had leptomeningeal disease. He had whole brain radiotherapy. and a variety of immunotherapies, but unfortunately has continued to have progressive disease. So when talking with him, we explored his insomnia history, and he spoke about having that he could go to sleep, but that once he was asleep, he had very active and sort of agitating, frustrating dreams, which he said it was like he was trying to solve the difficulties of his loss of function that he was struggling with. For example, the loss of function in his right hand, that he was trying to solve these difficulties at night when he was in his dreams. Can I just pause and check that everybody can hear me okay and can follow me okay? Great.
Yes, ma'am, we can. Yes, we can hear you clearly, ma'am.
Fantastic. Thank you. He said he didn't sleep excessively during the day. He had been diagnosed with depression by his GP and started on citalopram about 4 weeks earlier. His brain mets were progressing, and recently he had an increase in his dexamethasone to 16 milligrams, but that was reduced back to 8 milligrams, which was actually a baseline dose for him at present because he didn't have any benefit with the higher dose. He has epilepsy, focal epilepsy affecting the left side of his face predominantly, and was on Keppra, levetiracetam, 1,000 milligrams BD. And he lived with and was cared for by his wife, who was also very stressed and having difficulty sleeping as well, worrying about his situation. They had 2 daughters who lived in another state in Australia, but came home as often as possible to support. So I think this example perhaps shows that, you know, the insomnia can, or sleep disorders can have a variety of components. He seems to have perhaps a combination of 2 types of sleep disorder, which I'll talk about, with the one called parasomnia and then the actual insomnia itself, and many contributing factors that we see commonly in people with advanced illness, and with his and then also that overlap with depression, and that's also one of the clinical challenges when we're assessing insomnia. Are we dealing primarily with depression, or is the insomnia impacting on mood? Trying to tease out those sort of dimensions. So going now to look at, I guess, what we're talking about, there is an international classification of sleep disorders, and I think Dr. Seema will talk more about the classification and the different types, but essentially the idea is that there are primary sleep disorders and secondary sleep disorders. Primary include dysomnias and parasomnias, and secondary are due to medical or psychiatric conditions that give rise to insomnia. And under dysomnias, there are a number of different types of disorders of sleep, which is basically what that word means. For example, primary insomnia or hypersomnia, sleeping too much, narcolepsy, just sudden falling asleep, breathing-related sleep disorders, or such as sleep apnea, obstructive sleep apnea, or central sleep apnea, and then circadian rhythm sleep disorders. And then parasomnias are these unusual experiences or behaviors that occur during sleep. Perhaps that's what Mr. Arif was describing. Now, the diagnosis is largely dependent on how the patient describes their sleep. So a careful history is needed where you explore the details of the sleep-wake cycle with the patient. Is it difficult to get to sleep? How long do they wake up frequently? What is their experience when they wake up? Do they feel as if they've had a good sleep or not? Explore any sleep-related symptoms, the sense of fatigue or feeling rested or not, and the impact that the sleep has on the person's well-being, their mood, and how they are coping with the sleep disorder. The most common sleep disturbances seem to be insomnia, excessive daytime sleepiness, and the circadian rhythm sleep disorders. So just looking at insomnia specifically, this is really just described as the patient's subjective report of difficulty initiating or maintaining sleep, despite adequate opportunity and circumstances to sleep. And you'll find that definition in the Oxford textbook of palliative medicine. And that is associated with dissatisfaction with the quality or quantity of sleep. Now, the prevalence of sleep disorder or insomnia in the palliative care setting is it's quite difficult to get really good data on this. There is a large study that was reported in the Oxford textbook by Tunisin in 2007, and they in this study they pulled the symptom prevalence data of a number of symptoms, including insomnia, from 44 studies involving over 225,000 patients. And they kind of divided them between the symptoms seen before the last 1 to 2 weeks of life, and then symptoms seen in the last 1 to 2 weeks of life. And in their table, you'll see that insomnia is reported in 36% of patients in these studies, and was reported in only 28 of the 44 studies that they included in their larger pool. And in patients patients before the last 1 to 2 weeks of life. And in the last 1 to 2 weeks of life, it was reported in 14%. So in fewer patients, but there were only quite a small number of patients in that sort of, they called it group B in their study, in their analysis, and it only included 4 studies in that reported on insomnia in the last 1 to 2 weeks of life out of the 44 studies in the whole meta-analysis. So they don't explain why the incidence may be so much lower in the last 1 to 2 weeks of life. Perhaps it's because people are on more sedatives at that time. Perhaps the symptom just isn't as troubling at that time. It's not clear. It's not commented on. They do suggest that insomnia may be more common in men, and I guess make the perhaps obvious point that for all the symptoms, there's huge variation according to what assessment tool is used, and even more so if no assessment tool is used and they're just using doing kind of retrospective reviews of patients' charts. Generally, if a tool isn't used, then the only symptoms that get recorded will be the ones that the patient volunteers. And so many of the perhaps symptoms that patients may not think we as doctors are necessarily interested in may not actually be reported by the patient. There's also been some attempt to compare symptom prevalence in different life-threatening diseases. Again, this table comes from the Oxford textbook. And you can see for insomnia, there's quite a range of prevalence according to a number of different diseases: cancer, AIDS, heart disease, COPD, and respiratory and renal disease, I beg your pardon. And I was interested in the fact that there's such a wide range in the cancer patient group. And I'd be interested in people's speculation as to why that is such a wide range. Perhaps, again, it's not a symptom that is as commonly reported in cancer. Perhaps other symptoms take predominance, or I can't explain that wide range. 9% seems to be surprisingly low to me. Now, we can have studies that look at sleep disorders prevalence, but I think you can also go to Google and just look at, jokes about sleep disorders or jokes about insomnia or how common is it, and you'll find that it seems to be pretty much a common human experience if you go by the amount of interest that there is in the world of Google. I tried to find an amusing joke. I don't know if you know of Woody Allen, an American comedian, actor. So he says there are two types of people in the world. Actually, this is slightly hidden by the bar, so I don't know if I can read, but I think it says there are two types of people, good and bad. And the good people sleep well, but the bad people have more fun being awake. So there are many jokes about lack of sleep. So insomnia is important because it does cause problems, as we know, and they may be physical as well as kind of more cognitive. So poor daytime functioning as a result, where we feel fatigued, have poor concentration, impaired performance, malaise, can have behavioral problems, mood upsets, headaches, tension headaches, chronic pain. And I think pain in general is aggravated by insomnia or lack of sleep, and nausea and gastric upsets. And I think it's important to see, in depression, we also can see insomnia, hypersomnia, difficulty concentrating, fatigue, and it's very important to explore for the presence of depression when someone is having trouble sleeping, but also to recognize that not being able to sleep can also lead to behavioral problems and mood problems. So Seema, as a psychiatrist, will be able to talk to that much more competently than I can. So how do we assess insomnia? Well, just as we assess all symptoms, we need to take a careful and a curious history to characterize the symptom, to understand the impact on the person and on their caregiver, and to try to understand how they are trying to deal with the problem. Many people will be trying all sorts of remedies, complementary therapies, advice from friends and neighbors. So exploring how they're trying to deal with the problem, how successful they are, and what their attitude towards it is, whether they're starting to feel frustrated and distressed and anxious and fatalistic. So we need to understand how it's affecting them as a person. Sleep is such a fundamental life skill. And I think when I became a mother, I realized really that sleep is to a large extent, at least, a learned behavior, that babies need to learn how to sleep. It's not necessarily an automatic skill, and that good patterns need to be set up. Those patterns of winding down before going to bed, not overstimulated, regularity, all those things that helped me to get my children to sleep, I think still apply for us as adults. But I guess life becomes a little more complicated, and it can be difficult to maintain those good habits. And in particular, I just mentioned that those good sleep habits are really very seriously disturbed very often by admissions to hospital. I remember one patient who felt that he came to the hospice after a period of time in the acute hospital and really felt as if he'd been through some kind of torture of sleep deprivation, hadn't been able to sleep for at least 4 nights. The environment can be very noisy with a high level of distress, and many disturbances during the night for observations or because of their pain or other symptoms and associated problems like nocturia, etc. So, but particularly the noise levels can really impact. So to look at the assessment as I've shown here, we're trying to understand the sleep pattern details. Those terms I mentioned before. Is it what sort of sleep disturbance is it? What's happening in the sleep and wake cycle? What about daytime naps? What about their pre-bedtime habits? What are the consequences during the day? How do they describe their sleep problem? How severe is it? How much distress does it cause? And then the more comprehensive medical history as well, their medications, their other conditions, comorbidities, and a physical examination to look at obvious causes such as heart failure or where people that may be making it difficult for them to lie flat. Or many other conditions. So this is a example of a sleep assessment or of a symptom assessment scale, and you can see the insomnia symptom here, and this is a symptom distress scale, so how distressing each of these symptoms are. And as I mentioned earlier, the use of a scale increases the likelihood of reporting the symptom. So I think many of you are already using symptom assessment tools of one sort or another, and this just to encourage you to continue to do that. And then in addition to the clinical assessment, we have a possible investigations that might help to determine which kind of sleep disorder we're dealing with. And it's a good practice also to begin with to ask the patient to keep a sleep log for a week or so, just so that they focus in a little more on just what's happening with their sleep, and maybe bring their problem more to a sort of conscious level. And this is one example that I just picked up off the internet, but there'll be many others, and these are the kinds of areas you're asking the patient to record: for what time they go to bed, how long they think it took them to go to sleep, how many times they woke up, and how long they were awake for, and whether they felt rested, and any other comments they'd like to make. And then this is my final slide. So just some other investigations that might be helpful, and this kind of wrist watch monitor, it's like a Fitbit or something similar to that, can be very useful, and it appears that they are actually more accurate than self-reported sleep durations. So I guess they add a more objective measure, and then formal sleep studies. You may have sleep laboratories, Or now patients can wear these kinds of monitors and have their sleep monitored at home without having to go into a specialized center to do that, which makes it a much more accessible option for studying sleep patterns. So I'm actually just going to leave it at that, and would be very happy to have some comments or questions and some discussion if you would like to do that. I'll just stop sharing.
Thank you, Dr. Odette, for that excellent presentation. So I think we can have few questions because Dr. Odette might not be staying for a full hour. So if any questions you have, you can ask her right now.
Otherwise, I can ask you a question. How feasible would it be to have some kind of sleep study done for patients in your settings?
So Dr. Odette, we have a question by Dr. Araba. Like you have said, it's more common in men. So what is it possible reason?
I don't know the answer to that. Perhaps there's some. I don't know the reason. Would anyone else like to comment on that? It's not. It wasn't a strong finding in that large prevalent study. So I don't know how much weight to put on that comment in the study, but it was suggested that there seemed to be more men suffer from it. Seema, do you want to comment? Yeah.
Yeah,
Thanks.
most of the studies just report, no further exploration of the
Yeah.
reasons were done in these studies.
Yeah.
Because I think one of the areas, especially in palliative care, where it has not been studied much.
Yeah.
The sleep aspects, there are not much research done on this, isn't it?
I agree. It's when you look at it, it's surprising in a way, but I mean, whether it has any link to the kinds of illnesses, I don't know, is sleep apnea obstructive sleep apnea more common in men? Maybe some of the illnesses that give rise to insomnia may be a little more common in men, but I'm just speculating. Smoking, maybe. Maybe, sleep habits are different. Or I don't know, because I think both males and females have a lot of reasons to have disturbed sleep. So there's lots of good suggestions coming in the chat. Was decreased testosterone due to anxiety and stress? Would decreased testosterone lead to insomnia? Maybe. I'm not sure. Does it, Seema? Yeah, no, I'm not sure about that. Good suggestions, though. If there are no more questions, then maybe Seema, you'd like to continue the presentations?
Yeah, sure.
Thank you.
Yeah. Thank you, Odette. That was really enlightening to hear you talk about the whole global perspectives. I'll start with speaking a little bit about the Indian perspective from, what were the study findings. Yeah, it was a very informative. Thank you so much. And Shri, can I carry on?
Yes, Dr.
Yeah. Okay, let me share my slide. Yeah. Is it visible?
Yes, ma'am. Good to go.
Yeah. Okay. Thank you. So I'll start off by, describing what are the different types of sleep disorders that are there, and what are the, specifically with regards to insomnia, and how do we manage it. Before I start, thank you, Palliative India, for this opportunity. And thanks to all of you to be coming on a Saturday evening and attending this lecture so late into the evening on a weekend. Kudos to your dedication for coming and learning about palliative care. It's really encouraging for us to be speaking to such an audience. And this is Karunashraya. This is the hospice that I work in. This is a 73-bedded inpatient hospice in Bangalore. And the latest acquisition of Karunashraya is the excuse me, just sorry. Is KIPSAR, Karunashraya Institute for Palliative Care Education and Research. So the second building is KIPSAR, and we also have an MOU for training and education with Palliative India. Shri and Palliative India team, thank you for inviting me. Before we move on to the sleep disorders, this is the normal sleep architecture. We spend about 2/3 of our time awake and 1/3 sleeping. And in the wake cycle, the sleep cycle has sort of NREM and REM sleep. And, last time when we did the basic course, I think we had gone into detailed discussion about this. Normal adult sleep duration about 8 to 9 hours. And the REM and NREM sleeps come in stages. And there's a single cycle of the sleep is around 90 to 120 minutes. And each individual goes through 4 to 5 cycles in one night. The NREM goes through 1, 2, 3, 4 stages. Stage 3 and 4 are the slow wave sleep or the quiet sleep, and REM is the dreaming sleep. I'm sure these basics all of us know. And slow wave sleeps predominates in the first half of the night, REM in the later half of the night. And this is the slow wave sleep or the quiet sleep that decays as you grow older. But REM is generally preserved throughout the night. So for the elderly, as you grow older, the NREM sleep is the one that gets affected. And that is also one of the reasons for insomnia in the elderly population. So as per the International Classification of Sleep Disorders, there are 7 major categories. We are just talking about the first one. So insomnia, then you have the sleep-related breathing disorders. Then the third category is the central disorders of hypersomnolence, circadian rhythm sleep-wake disorders. There are parasomnias, sleep-related movement disorders, and other sleep disorders. There are 7 categories. And it's very important for us to know, because sometimes patients come and tell us, I'm having disturbed sleep, right? Whether it's insomnia, whether it is a parasomnia, whether it is, a circadian rhythm sleep-wake disorder that person is experiencing, it's extremely important for us to know what is this individual going through. So to further subcategorize each of these categories, insomnia is divided into 3 types: chronic insomnia, short-term insomnia, and other insomnia disorder. So today's discussion, I'll be focusing primarily on the insomnia aspect of it. And sleep-related breathing disorders are primarily obstructive sleep apnea, central sleep apnea syndromes, and these also have further subcategories under them. And when we talk about circadian rhythm wake disorders, you have delayed sleep wake phase disorder, irregular sleep wake rhythm disorders. There are multiple categories under each of this, and it would be very interesting for all of you to go through it once, so that we have a broad idea about, when we talk about sleep disturbance, how many subsections of sleep disturbances are there, and management of each of this may vary depending upon, what is causing it. So it's very important for us to, understand. This is a very neglected aspect of what we study, I feel. So it's important for us to know what exists out there and how to evaluate. Coming to the Indian context about insomnia. This was a study that was done in July to December 2017 in AIMS. I did a scoping search to find out how many studies about sleep was there specific to India. Very, very few, right? And this was one study which was done in 2017 in AIMS, I think. And about 100 adult patients in the OPD were asked about the difficulty they had with sleeping. And as you can see, quite a few of them complained of insomnia, and the sleep quality in the study was poorer in women than in men, which is very different from what Odette just mentioned. Why? We don't know, because this just reported, among other things, that sleep was disturbed. There was another study again, which was done on 100 head and neck cancer patients. And the top 4 symptoms they complained about was pain, insomnia, loss of appetite, and fatigue. Okay, and the intensity of insomnia was quite high. If you can see here, SLS sleep, 66.67%, was the intensity of the insomnia that they said. So again, if you can see some of the one of the most common symptoms, but I would say one of the symptoms that is highly undertreated and understudied also. There are not much research about it at all. It's just people state it as part of the symptom cluster. There is a sleep disorder. What is the type of sleep disorder? Why does this occur? Not further much studies have been done in palliative care about it. So this was again a study that was published. It was a multi-centric study in the Asia Pacific region, and that was done in multiple countries. And again, one of the common symptoms reported was fatigue, loss of strength, pain, and sleep disturbance. And if you can see, more or less, 60%, over 60% of the patients complained of sleep disturbance. So I think it's time that we brought it out into the conversations and dialogue and spoke about how do we manage it, how do we treat it, and try to learn more about what is happening. So next, I'm going to start off with a case, which I want to keep it quite interactive. So I would appreciate if we would unmute and answer this. Mr. C was a 64-year-old gentleman diagnosed with colon cancer and with liver metastasis, had persistent right upper quadrant abdominal pain, suboptimally controlled despite the regular doses and breakthrough doses of morphine, and has been complaining of poor sleep for the last 5 days. No difficulty falling asleep, but wakes up at 4 a.m. in the morning. Generally, he wakes up at normal waking up time is 7 a.m. He's very quiet, becomes very tired and inactive, and frequently naps during the day. So how would you proceed with this patient?
Madam, the pain is suboptimally controlled, madam. So
Yes.
if you optimize the pain, maybe he could get better.
Absolutely. Okay. So first manage the pain and see whether he would get better. Any other suggestions?
Ma'am, as the patient is taking frequent naps during day, so we can maintain sleep hygiene, like obviously.
Absolutely. Yes, I'm not able to see who's talking. So if you can just tell your name before you talk, okay? Because I can just my slide and your faces are not visible. But thank you for that answer. Yes. So possibly you look at the frequent naps that he is having and see what's going on.
Yes.
Anybody else?
Dr. Kale from Nagpur.
Yes.
Madam,
Yeah.
he's already sleeping, taking naps in the day, and he's inactive, as you said. So person is inactive, his body does not need that much of sleep. And when somebody is taking naps in the daytime and he's inactive, then his body is inactive. So he doesn't need that much of sleep. So his sleep insomnia is due to his habit of taking naps. He should not take naps and remain active. Then he can have a nice sleep in the night.
Yeah. Yeah. Okay.
Okay, ma'am. Then the early waking up could be a symptom of depression.
Absolutely. Thank you so much for all your suggestions. Yes. So basically, the thing is to look at, find out what all is contributing to the insomnia in this gentleman. Remember, it's in palliative care, it is not a single cause, isn't it? There are multiple reasons that can provide. So to put in a diagnosis, this gentleman has got what we call a short-term insomnia disorder. Why short-term?
5 days only.
It's just yes, it is just for last 5 days he has been experiencing. Also, it is related to a stressor, isn't it? What is the stressor here?
Pain.
Absolutely. It is uncontrolled pain is the stressor. And generally in short-term insomnia disorder, symptoms generally last for less than 3 months and it resolves, or if there is a stressor, like immediately after the diagnosis of cancer, you've told this person that he's got a metastatic cancer. Maybe he didn't have any pain, but still he might have insomnia because diagnosis of cancer is a stressor. It takes times to adjust and to accept the diagnosis. So he might experience during that period insomnia as part of an adjustment disorder, So adjustment insomnia generally fades away or resolves in 3 months' time. And what patients need at that time is possibly psychoeducation, sleep hygiene, okay, and telling them how they can manage this insomnia, not directly write a benzodiazepine. Okay, sleep is impaired. Let me give you lorazepam or alprazolam. I think that's something everybody likes to give, isn't it? Absolutely. Somebody has written liver function alters sleep pattern. Yes. So we have to rule out multiple causes, isn't it? Whether it's organic, whether it's psychiatric, or just it is a reaction to a stressor, right? Once you control the stressor, patient's insomnia resolves and patients sleep habits come back to normal. Okay, so just before exams, I think all of us experience insomnia, isn't it? That's a short-term insomnia disorder. You're not able to sleep. Even if you sleep, you'll suddenly get up in the night if you're an anxious person, right? Exam phobia if you have. So that's something that we need to keep in mind. Now let's look at him. His pain has been optimally controlled with medications, but still he has been struggling with sleep since the last 4 months. Reports most of the days he falls asleep by 9 p.m. but awakens multiple times at night, and after 4 p.m. he's completely not able to sleep. But once or twice in a week he gets good sleep. Feels fatigue, he feels listless and is continuously drowsy throughout the day. What is this now? How would you manage this individual?
Definitely, it's actually the stress that is causing all of this, because he's feeling fatigued and listless, which is causing him the definitely lack of sleep during the night and drowsiness during the day. So we will focus mainly, I think, on the anxiety part of the patient and psychological counseling, and maybe the hygiene that I was already mentioning, how he can decrease the naps.
Yeah, here now your pain is controlled.
Yes.
Right? And but since the last 4 months, he has been struggling with this. Would you still go ahead with only the psychological support and psychoeducation, or would you think this is something much more severe, much more serious?
Yes, actually, the time mentioned is like 4 months, so it is it is bothering him from a long time. So definitely we can add on some medications.
So somebody has written, will melatonin help? We'll discuss that. Okay, when we come to medications and pharmacotherapy, we'll discuss it. So when we look at the diagnosis right now, we are looking something which is little more severe, isn't it? This is chronic insomnia disorder. I told you there are 3 types. One is adjustment insomnia, short-term insomnia. The second is chronic. Here there is a sleep disturbance. When patients say there is a sleep disturbance, you should ask them, is it difficulty initiating sleep? Is it difficulty maintaining sleep? Or is it early morning awakening? Okay. When do we say if the difficulty initiating sleep after going to bed, okay, if the sleep comes more than 20 minutes in children, after 30 minutes also patients are not able to sleep, then there is difficulty initiating sleep. Difficulty maintaining sleeps, there is periods of awakening in the middle of the night, and for over 20 minutes in children and over 30 minutes for adults. They get up and they're awake for over 30 minutes. Only then sleep maintenance is difficult. I always get up in the night. When I roll over from one side to the other for 5 seconds or 1 minute, I'm awake, but I go back to sleep, right? So that is not difficulty maintaining sleep, right? If it is more than 20 minutes or more than 30 minutes, you are awake in the night, and then you get up, you walk around, you drink a glass of water, and then you wait, and then slowly you fall asleep after 30 minutes. That is difficulty maintaining sleep. Waking up earlier than the desired, more than 30 minutes before your normal waking time. So in Mr. C, where does he fall?
Waking up earlier.
Waking up earlier. We don't know about difficulty maintaining sleep because I have not mentioned the time period that he gets up, but I have not mentioned the time period. So you don't know about it, isn't it? Then sometimes this in children especially, that might be resistance to going to bed on an appropriate schedule, difficulty sleeping without parent or caregiver intervention. Okay. So point number one or more of that should be there. Point number two, one or more should be there. There might be fatigue or malaise, attention, concentration or memory impairment, impaired socio-occupational functioning or academic performance, mood disturbance, anxiety, irritability, daytime sleepiness, behavioral problems like aggression, anger, reduced, a hungry man is an angry man. Also, a person who doesn't sleep in the night also can become very irritable, isn't it, in the daytime. Reduced motivation, energy, initiative, proneness for errors and accidents. And that is the reason, isn't it? When we put some medications, we tell them drowsy, do not drive. Concerns and continuous ruminations and concerns about dissatisfaction with sleep. And then the third criteria that you look at, frequency. Sleep difficulty and associated consequence occurs at least 3 nights per week. Okay. In Mr. C, how many nights was he able to sleep? Only if you have read the case, 1 or 2 nights he was able to sleep well, isn't it? Which means he fulfills the frequency criteria. Duration, sleep difficulty should be present for at least 3 months. So he has 4 months of sleep. Yeah. Adequate opportunity. Sleep difficulty occurs, this is very important, despite adequate opportunity and circumstances for sleep. Okay. So, and relationship to another condition. The problem is not explained by another sleep disorder, a coexisting mental disorder like depression, a coexistent medical conditions, and are not attributed to the physiologic effects of a substance or a drug, right? So if all these are fulfilled, then you call it as a chronic insomnia disorder, right? Shall I move on to the next slide? Yes. So,
Yes, madam.
yeah. Now look at the differential diagnosis. We have recommended sleep times duration. This is recommended. Not everybody follows this pattern. Some people need lesser sleep. Some people may need more sleep. But generally for an adult, it is about 7 to 9 hours of sleep. Okay. I sleep only for 5 hours a night. Mine, so do I function adequately? I function absolutely adequately. So this is the norm. It is, this is the average thing that they say. It's not that everybody has to fit into it. Okay. So how do we make out whether you're getting sufficient sleep or not? Is your difficulty or insomnia insufficient sleep, or is it an insomnia disorder? First, look at your ability to sleep. If you're able to hit the bed and go to sleep immediately, you're fine. Okay. Patient is able to sleep when given the opportunity, patient is absolutely fine. But even when they're given good opportunity to sleep, if they're unable to sleep or the sleep is disrupted, it is more likely an insomnia disorder. Right? Now, in insufficient sleep or sleep deprivation, opportunity for sleep is inadequate, meaning patients may have severe pain, right? So they are not able to lie down flat in the bed, or they might be very anxious and they are not able to sleep. So this could be, insufficient sleep. But in an insomnia disorder, pain is adequately controlled, right? Anxiety is handled adequately. He's given enough time, and the space and the opportunity for sleeping. Lights are switched off. He's sent to a room to sleep, right? But still he is not able to get a sleep. That is more likely to be an insomnia disorder. In insufficient sleep, short sleep duration due to inadequate opportunity, especially when patients are in the hospital, they will tell, "Neend nahi aaya, I was not able to sleep." Okay, whether it is, most likely it is because of insufficient sleep, because nurses keep coming and disturb them and wake them up. People keep switching, the lights are on, so the opportunity of sleep is not there. It has nothing to do with the ability to the sleep, right? So that's how you look at differentiating between an insomnia or between a sleep deprivation or an insufficient sleep. The other thing that you have to look at is other comorbidities, other sleep disorders that coexist with insomnia. Where if patients talk about sleep onset difficulty, I cannot fall asleep at night, I lie in bed for hours and I'm unable to initiate the sleep, can't fall asleep. Look at restless leg syndrome, right? Especially in patients with renal insufficiencies, etc. Restless leg, uremic patients, restless legs are very common. Is it restless leg syndrome? Also, you have to do a delayed sleep-wake phase disorder, which if they keep a sleep log, okay, so they fall asleep at a later stage, like they may not sleep until 12 o'clock, but they will also wake up at maybe 10 o'clock in the morning, right? So that is, the sleep cycle has shifted away. Instead of falling asleep at 8 o'clock, the sleep cycle shifts by maybe 3 hours, 4 hours, up to 12 o'clock. But that 7 to 9 hours of sleep is there. But it starts from 12 o'clock. So and they sleep late, they wake up late. So that's something that you need to ask them. We call it night owls, right? Some of us prefer studying in the night. Some of us get up early in the morning and study, right? So we need to find out. The other thing, if they say there is difficulty in maintaining sleep, find out whether there is sleep apnea or periodic limb movements are there. Those are the questions that you need to ask if there is difficulty maintaining sleep. If there is early morning awakening, it's more likely because of depression, right? The sleep cycle, sleep REM, NREM sort of shrinks, and there is that advanced sleep-wake phase disorder. They sleep early. Some people sleep early and get up early. So that is something you have to look for, and also look for depression. One of the common symptoms of depression is early morning awakening, as someone rightly put in the chat. That is something that you have to rule out and evaluate and look for other symptoms of depression. Some patients complain of decreased sleep quantity. That is because they get insufficient sleep. They are either ruminating, thinking too much, or there is pain that is disrupting the sleep. These are things that you have to clarify. So whenever somebody complains of sleep disorder or insomnia, we have to look at all these aspects. What are the risk factors for sleep disorders? Physical symptoms. Primary 4 physical symptoms: pain, breathlessness, cough, and hiccups. There is evidence to show these are the ones normally that is associated with sleep disturbances. Of course, emotional distress and psychiatric illness is something that you always have to rule out, whether there is depression, whether there is some syndromal distress that is there, fear, anger, you need to explore. Environmental factors, is there enough opportunity for these people to sleep? Okay. If they are in the hospital, sometimes the environmental factor can cause insomnia. Decreasing, somebody mentioned, patient with low activity will have Less sleep, yes. Decreasing performance status also can precipitate insomnia. Bedbound patients tend to nod off at different points in the day, so the sleep cycle gets disturbed. Sometimes it's medication side effect, sometimes certain diseases, heart failure, Parkinson's disease, COPD, then liver issues like, liver failure, cancer per se, organic causes per se can precipitate primarily sleep disorders. So what do? We take a comprehensive history. What is the type of sleep disturbance? Is the difficulty initiating, maintaining early morning awakening, or you're sleeping for an adequate time, but you're not feeling refreshed about it. So that is something that you need to know. When did it start? OPQRSTUV. You need to start this, and you have to ask them to document the sleep schedule. Look at the time to bed, time to fall asleep, when do they wake up, nocturnal awakenings, what do they do before they go into the bed, do they watch TV, do they drink alcohol just before, do they smoke before going into the bed, what are the compensatory strategies that they are using. Okay, sometimes they tend to drink a bit of alcohol so that they sleep well. What are they using? Addictive substances? Are they taking any drugs? What is the environment of the bedroom? Time spent in bed, and all this need to be taken into account. This all gets documented in the sleep schedule. Okay, and evaluate this daytime function. One of the main aspects of insomnia is if for 2 or 3 days because of pain a person doesn't sleep, the 4th day what happens? The stress of whether I will be able to sleep or not starts. They start catastrophizing. Will I sleep or not? The minute you hit the bed, you associate with negative thought and that worry. Am I going to be able to sleep or not? Which is extremely common. So this is something that we have to help them to handle. Identify what is the precipitating factor, perpetuating factor. Are they taking coffee, nicotine, medications, and neuropsychiatric history? This is what you do in the sleep evaluation. And medications that contribute to insomnia, quite a lot, especially in palliative care. You have anti-dementia medications, you have anticholinergic that you use, beta blockers can cause, bronchodilators can cause, steroids can cause. There's a whole gamut of drugs that can precipitate insomnia. What about morphine? What about opioids? You think opioids can cause insomnia?
Yes.
Yes. It can cause insomnia. Let me see how. Yes, very good. So it does cause a decrease in the REM sleep by 5%. It can decrease the deep sleep, actually NREM, slow wave sleep. The deep sleep, it decreases by 75% IV morphine, and almost 50% oral morphine. See, 50% of REM sleep and 30% of slow wave sleep. Okay, so it does change the sleep architecture. Okay, that's something that we have to keep in mind. Okay, about morphine too. So am I clear so far? Can I go ahead?
Yes.
What is the time? I don't have my watch. Do I have time?
Yes, ma'am.
Yes, ma'am.
Yeah. So when you look at treatment, what do? You improve the sleep onset, latency. You increase the total sleep time. You allow them to have a good night's sleep with reducing the awakening, so that the efficiency of sleep, the efficiency depends upon your cyclical sleep, both equal time, NREM, REM has to be equal. So the sleep architecture should not be disturbed with any of your medications. So that is your goal. The quality of sleep you try to improve, and you reduce whatever daytime symptoms of insomnia that come in, you try to reduce that. And you ensure that you continue to treat until it gets maintained, the sleep architecture is maintained so that the relapse chances are less, and avoid hospitalization. Remember, hospitalization for insomnia, the hospital environment causes hyperarousal. So as far as possible, maintain patients at home in familiar circumstances as far as possible. So what are the pharmacotherapy? There are two types of drugs that we use. What is sedative? What is a hypnotic? Guys, anybody wants to take a call on this? You would have read, right? Sedative, hypnotic. We read in the books, right? What is it?
Sedative puts you to sleep. Hypnotic, you lose consciousness.
Somebody wants to read this?
Ma'am, sedative decreases the decreases the activity.
Read. Yes.
Sedative decreases the activity, moderates excitement, and calms the recipient. And the site of action is the limbic system. While as the hypnotic produces a drowsiness and facilitates the onset and maintenance of the sleep that resembles natural sleep in its electroencephalographic characteristics, and from which the recipient can be aroused easily. And the site of action is midbrain and ascending RAS.
Reticular activating
system.
Okay. So understood the difference? Sedative is sort of, puts you to sleep, calms you, reduces your excitement, right? But does not maintain the sleep architecture at all. It's, in fact, it disturbs the sleep architecture, right? Whereas an hypnotic is something that helps you the maintenance of sleep architecture, and that resembles normal sleep. So we have benzodiazepines, benzodiazepine receptor agonists, sedating antidepressants, second generation antipsychotics that you can use for sleep, right? Haloperidol is an antipsychotic. Antihistamines you have melatonin and its agonists and orexin receptor antagonists. Okay, so these are all the pharmacotherapy agents that we have. When we look at benzodiazepines and their receptor agonists, benzodiazepines, we have the usual lot: oxazepam, trialzolam, lorazepam, alprazolam, diazepam, clonazepam, and nitrazepam. We have all this, and you have to remember, if you want to use benzodiazepines for sleep, they cause tolerance, they can be addictive, and over a period of time, an increasing dosage you will need to use, and sometimes they do disturb the normal sleep architecture. Okay, and alprazolam, as you can see, the half-life is anywhere between 6 to 20, depending, anywhere between 6 to 20, yeah, depending upon it's a very short or intermediate acting benzodiazepine. So it is useful, short acting are useful when you want, there is difficulty in initiating sleep. But in a person like Mr. C, who has no difficulties in the sleep onset, but has difficulty maintaining sleep and has early morning awakening, it is better to use a long acting or an intermediate acting benzodiazepines like lorazepam or clonazepam, right? So specifically, I prefer using lorazepam because the half-life is around 8 to 10 hours. So that is the duration of sleep you require in the adult. So by the morning, it is, goes out of your system. Clonazepam has a very long duration of action, almost, 18 hours, right? When you look at it, half-life is 18 hours. So it has a tendency to accumulate in the body, right? Within 12 to 24 hours when you take it, sort of, and especially in patients with hepatic failure or renal failure, it has active metabolite, which like morphine will accumulate, and it can sort of have more side effects, cause falls. So I generally prefer lorazepam when we in palliative care. Then you have benzodiazepine receptor and agonists, which more or less maintain the sleep architecture, like is a S-zoplicon, zolpidem, and zaleplon. These are certain drugs that that are also available, and these are zaleplon is very short acting with only with a half-life of 1 hour, so not generally used, but zolpidem with 2 to 4 hours of extended release tablets are something that can be used for maintenance of sleep. Then you have melatonin and melatonin receptor agonists. You have 3 mg tablets are available. No evidence for use as a hypnotic. It's a chronobiotic. It influences the circadian rhythm. So this is a good drug when there is a sleep-wake cycle disorders, I said, delayed sleep onset disorder or advanced sleep onset disorder. Melatonin is a good drug to use for them. And there is no evidence for its use as a hypnotic. Only for insomnia. It is meant for other dysomnias. Okay, then you have melatonin agonist like rameltion or agomelatine, which are also available for use. The other medications are orexin receptor antagonists. I have not used any of this so far. Then, of course, there are the sedating antidepressants. Many of our palliative care, we treat them for neuropathic pain. We put a small dose of amitriptyline that can itself be sedating. Mirtazapine is an antidepressant. Trazodone, especially in patients with dementia, trazodone is known to reduce the behavioral symptoms as well as can cause sleep in them. And antipsychotics, olanzapine and quetiapine are also sedating. So if in case there is a sleep disturbance, if you and a behavioral issue, you can use this. And our antineuropathic agents like gabapentin and pregabalin are also sedating, and they also can be used in conjunction if you're treating for neuropathic pain for sleep. So whenever a patient comes to me with pain and insomnia, sometimes the pain medications itself can cause sleep and you don't have to put anything more. If you put you start morphine, along with that you start something for pain, chances are that the patient may become drowsy. So when you choose any drug, age of the patient, look at the risk of sedation, look at comorbidities. Remember, delirium can worsen with benzodiazepines and benzodiazepine receptor agonists. In end-stage COPD, sometimes benzodiazepines can worsen the respiratory symptoms. Look at whether there is pharmacokinetics and the drug interactions of the drug that you're using. Look at adverse effect, availability, cost, and chances of any allergy for the drug. And then non-pharmacological management include cool, well-ventilated room, limiting screen time at night, lifestyle modifications, exercise to a certain extent. Even if it is bed-bound, passive exercise and movements of limbs can be done. Promoting physical comfort, healthy sleep-wake cycle, go to sleep at a regular time every night and minimize as much as disruption as possible. And there are strong recommendations for multi-component cognitive behavioral therapy for insomnia. There is a good recommendation for that, which uses multiple techniques, right from relaxation to stimulus control to sleep hygiene, to empower patients to sleep well. Less recommendation for brief therapies, stimulus control, sleep restriction therapy, relaxation therapy. There is less evidence, and multi-component therapies are always much more effective than single component therapy. So what does cognitive behavioral therapy for sleep apnea, for insomnia do? It combines stimulus control, sleep restriction, relaxation. It combines and makes it a multi-component therapy. So these are things that you can use. And there are other less evidence for plain cognitive behavioral therapy or biofeedback, sleep retraining, mindfulness. There are not much evidence for this. And final slide being, when do you stop therapy? Generally, long-term pharmacotherapy is not recommended, but it might change in palliative care patients. But there are no specific guidelines for palliative care patients, generally prescribed for short periods of 1 to 3 weeks. By that time, you teach them sleep hygiene, you do cognitive behavioral therapy for insomnia, which will take care of the sleep aspects, and then you can bring down the pharmacotherapy. Benzodiazepine receptor agonist that you can use for as long as 6 months. And sometimes try drug holidays. If sleep has stabilized for at least 4 weeks, you can discontinue the cognitive behavioral therapy for insomnia. Yeah, so that's the final point of the presentation. And before I end, I would like to remind all of you that IAPCon 2023 is in Bangalore. It's in February 10th to 12th. We have very interesting sessions, 9 tracks for specific tracks for the IAPCon. One of the tracks on the second day is about track 5 is ICU palliative care. So like that, we have neurology palliative care, nephrology, oncology, cardiac, pulmonology. We have all systems tracks are there. The last day is mostly research. And then we have 12 very interesting pre-conferences happening. So please go and register for the IAPCon. Thank you.
Thank you so much, Seema. I also want to emphasize on registering for the conference. That's going to be a lot of learning. So please do register if you have not done so far. Thank you so much for the wonderful session. It's a very, very important, and how much ever you hear about insomnia, it's still a lot to learn more. Thank you so much for the wonderful session. We'll just spend 1 or 2 minutes if they have any questions from the participants. You can unmute or talk, or if you have any question, just type it in the chat. I know that she has been answering, all the chats through the presentation, but if you have any specific questions, please ask.
Can I ask a question, Meenakshi here?
Yeah,
Yes, please.
So just very elderly patients, 80 plus, often the family complains they're not sleeping in the night. Very difficult to find out, is it onset? They're not completely cognitively intact also sometimes. So what is the drug which can, give the caretaker also some rest in the night and the patient? Which drug should we go to?
You're talking about patients with dementia, elderly patients with minimal cognitive impairments, possibly dementia.
Some senility probably, and then of course cancer, and then altogether they are, stressors are there, but definitely it's not pain. There's no pain, breathlessness. They are bed bound due to their disease or other functional reasons, but they're not sleeping very well. And towards the end of life, it becomes worse. With delirium and all setting in. So what is the drug which can predictably and consistently put them to sleep and keep everybody calm at night? Because they get very harassed, especially the caregivers get very harassed. You give haloperidol, it sometimes works, sometimes doesn't work, takes a long time. So what is the drug that we should go to?
Yeah. So I think one of the first things that you need to do is to identify whether these patients with cognitive impairment are more prone for delirium, right? So we call it sundowning. The confusional state starts towards the evening times. Is that what is causing the problem? If there is a component of delirium in it, then Q-tipin is a very good drug to give. A very low dose of Q-tipin, around 12.5 mg, you can start with, given that they are elderly. Okay, you can start with. But remember, with the elderly, the metabolism of the drug is very, it takes a lot of time to metabolize. It may not be as, the pharmacokinetics may not be as efficient as in the adults, right? So in the very old, frail elderly, it is a good idea to give the drug well before the bedtime. So probably I generally recommend giving it by 6:37. So it takes a lot of time to get absorbed, and by 10 o'clock they are asleep. Otherwise, you give the medications at around 7:38 or even 9 o'clock, and they don't sleep till 12, and then they are drowsy in the daytime. Okay, so morning drowsiness comes in. So it's a good idea to give it early. Now that is in case there is delirium associated with it. If it is just dementia and elderly senile dementia and patients are not behaviorally, not restless or agitated or confused, but just have insomnia, then doxepin and trazodone, very low doses, have shown to have good effect. But you have to keep in mind, they can cause hypotension in the night if they have to go into the toilet. Chances of falls are there, right? So these are things that we need to keep in mind when we prescribe. So what is the cause of insomnia? You may not be able to tell whether it's sleep onset, maintenance, or early morning awakening, but you definitely can rule out delirium, isn't it? So if it is delirium, Q-tipin. If it is no delirium is there, it is just sleep, difficulty with sleep, then probably trazodone or whatever. But benzodiazepines, definitely I would avoid, which is one of the commonest drugs that we use, which is something I would definitely avoid. Yeah.
Ma'am, this is Dr. Sashikala here.
Yeah.
I just wanted to know, I was to present that case today, but unfortunately I could not do so. So I wanted to share my experience about a patient of mine who is in a hospice, in a government-run hospice. She was a patient with cancer, and so she was receiving medications from the government hospital. So I tried using music therapy for her. So I used to from my guru, I used to play specific music. It was a common hospice where all of them were there. So I started playing music there, and it actually helped her and also the other elderly patients who are housed there. So, what is your experience with using alternative methods or something, like music, or what was your experience, ma'am? Is there a role for it?
Absolutely. Thank you, Shashikala, right?
Yes, I'm Sashikala. Yeah.
Thank you, Dr. Shashikala, for that. Yeah. So one of the cognitive behavioral therapy for insomnia, one of it is relaxation, right? So for different people, they relate to different things and they are able to relax with different things. So for some, it could be music therapy. For some, it could be probably, for some, it could be art, right? For some, it could be just mindful breathing, right? So it depends, like there is evidence that these therapies can be helpful to reduce stress or anxiety, and that in turn helps the patients to sleep better.
Okay. Yes, ma'am. Thank you, ma'am.
Yeah.
There are many questions in the chat. Are you able to access it, Dr. Seema?
Yeah. So I think somebody has suggested low dose doxepin. Absolutely. There is enough evidence for, as I said, for doxepin to be used in insomnia. So Christopher Vasant has said, I have 3 questions, ma'am. Can we use placebo for short-term insomnia? I treat many patients with cervical cancer. If patients are already on morphine, amitriptyline, and pregabalin, and still they have sleep problems, which is preferred medication, diazepam, lorazepam, or zolpidem. I usually ask my patients to have a chat with the sister. If they have a disrupted sleep and could not go back to sleep, is it a right approach? Yeah. So placebo for short-term insomnia, only if patients are suggestible, and I don't know, but generally, when they complain of insomnia, it is important for us to find out why it is happening. I have never used placebo, but if you have any experience, you could tell. I have no idea about that. When it comes to patients who are already on morphine, amitriptyline, and pregabalin, and still they have sleep problems, which is the preferred medication. Okay, now here comes the problem, because we have seen that morphine can reduce sleep efficiency, right? I've told you, they can look, it can affect the REM sleep, and it can also affect the NREM sleep. So though it might not affect the duration of sleep, but the patient does not feel rested enough, right? So at that point in time, when you put diazepam or lorazepam, you are again further distorting the sleep architecture. You're not restoring the sleep architecture for the patient, right? So at that, yeah, so at that point in time, probably if the patient, looks at renal function, everything is intact, probably a short course of zolpidem might help. Also ensure that sleep hygiene and cognitive behavioral therapy is done to the patient. I mean, you teach the patient that. For the short term, you can use zolpidem to initiate sleep because more or less it maintains the sleep architecture. But at the same time, don't leave it at that. It's important to teach sleep hygiene to this patient and also to initiate CBTI, which has good evidence of, treating insomnia. It is very effective.
Yes, ma'am.
Some more questions coming up.
Insomnia in PVOD patients. Can you expand that?
I think, doctor, do you mean peripheral vascular disease, or I don't know? Yeah. Okay.
In those with peripheral vascular disease?
Yeah, I think so. So is there any contraindicated drug in peripheral vascular disease?
I'm not
Seema?
aware.
Okay.
I think you follow the same pattern of treatment, but avoid if they have a history of smoking, then probably that is something that you need to look at. Second, I would probably avoid benzodiazepines in these patients. If they are nicotine dependent, then withdrawal also can trigger. I mean, per se, that I'm just looking at the causes of peripheral vascular disease and telling, but generally I'm not aware of any contraindications. I would follow the same pattern and the guideline that is used in the general population, I mean, in palliative care.
Okay.
And I think next question is regarding lorazepam. People sleep only for 1 or 2 hours with lorazepam. Then
What should we do? Okay, so then probably you need to look at whether there is underlying depression or any psychiatric issue that is contributing to the sleep disturbance. Generally, if with lorazepam, you are just initiating and probably maintaining the sleep for some time. See, one thing that happens is if patients have been previously on a benzodiazepine, chances of tolerance might be there. So a small dose may not be effective enough. In patients who are alcohol dependent or with a history of smoking also, they tolerate the tolerance to benzodiazepines is high. So probably higher dose might be required in such individuals. So these are two things that you have to rule out. The third thing is to see whether there is any depression. Because if there is depression and the sleep disturbance is primarily secondary to a major psychiatric disorder, then your lorazepam is not going to help much. You will have to treat the underlying cause. So probably these are things that you need to evaluate and look at. So the next question is, my relative age over 80 with insomnia is taking melatonin, but she still complains of early awakening. What to do? Probably look what is the dosage. You look at the dosage. Then you look at the timing of the melatonin, whether you can adjust it and see. And what about the other functionality of this individual? Sleep hygiene is something maybe that you need to look at in that individual. Mansi Joshi asks, what is the safe drug when the risk of fall is more? There is no safe drug as far as sedatives or hypnotics is concerned. All of them have that, what do you call it? All of them have a tendency to cause falls, so we have to be careful. So then
I think there is a question regarding children. Insomnia, is it common, and how do we manage insomnia in children?
Insomnia in children is something I'll have to read up a little bit more, but I would still avoid benzodiazepines and look at tricyclic antidepressants, TCAs in young children, like what you give for nocturnal emesis, right? Imipramine is what is given. So these are safe in children, and certain antidepressants, sedative antidepressants are also safe in children. So rather than use benzodiazepine, I would prefer to use small dose of antidepressant, especially TCAs in young children for insomnia. More on it, I will have to look through because I'm not very familiar with treating just insomnia. Insomnia can occur in children as part of a psychiatric illness. Yeah. In renal failure, which drug is suitable? Depends upon the degree of renal failure. If it is anything, if the renal clearance is above 50, I think you can give most of the drugs can be used, but at a lower dosage. But it's generally better to avoid clonazepam because of its long action. But otherwise, we can use or with reduced dosage. Srilata asks, can melatonin be given for long periods? Yeah, people do take for, yeah, it can be given. So I think that exhausts the question.
Thank you so much for all the answers, patiently answering each question probably. And thank you so much for the participants because you are asking all those questions, getting clarity, because this is a very, very important topic. I session many times, but then still I'm confused when it comes to a patient. Then we still think, okay, which one to give? So many things to consider, when to stop, how long should we? It's always, I think, every patient needs discussion and so much, rather than just prescribing benzodiazepine. At least that is one thing that we have to take away from
Benzodiazepine,
this.
I think one thing about psychiatry is, you know, we keep telling don't use benzodiazepines. I think every other specialty at the drop of a hat, yeah, benzodiazepine is, you know, prescribed. But be very mindful when you use benzodiazepines.
Yeah. So Dr. Aftab is telling we
Could
didn't
not
sleep
sleep.
during the insomnia class. So, but unfortunately, Odette had to sleep because I was so surprised when she told that she will take the session at 1:30 at the night. So maybe one last question from Dr. Meenakshi: how to taper?
Yeah. So there is a specific guideline, you know, like we do dexamethasone, right? If it is short term, you don't need to taper. Within 3 weeks, you don't need to taper, you can stop it. But if it is a long duration, then you go by 20% reduction, you can bring it. Also, when you switch benzodiazepines, like we have opioid conversion rates, right? There is also a benzodiazepine conversion table is there. So if you want to switch from alprazolam to lorazepam or from clonazepam to lorazepam, there is a conversion table. Most of the time, like when people switch or change benzodiazepines, it's done arbitrarily. Antipsychotics and benzodiazepines also have a conversion rate just like opioids. So that's something that you can look up on the internet. You will get those conversion tables and you can do accordingly. You can manage accordingly.
Thank you, Seema. Thank you so much. Everyone is thanking you for a wonderful session. Thank you so much for agreeing. Although you are very busy with the conference programs and multiple other training programs happening here. Thank you so much.
Most welcome. It's always a pleasure.
Thank you. So to all